But those experiences that I had as a small boy were influential in me deciding to become a surgeon. To me, being a doctor meant being a surgeon. There was never any idea of becoming a physician or a GP. There's been times over the last 10, 15 years when I've seen families of children who've been in similar positions as myself as a 5 or 6-year-old boy. And these circumstances are quite difficult for me, understanding exactly what they're going through. However, whatever you guys go into, whatever career paths you follow, please use your experiences now and those that you will have in the future to help you be a more effective and sympathetic person. Use every opportunity that you have to help you decide and guide the choices that you will make that will affect your future. I look very fondly back at my time that I was at Quakes when I threw myself into everything that was on offer. I played rugby and hockey for the school and became first team captain at hockey. I played cricket for the first team, swum, went on skiing trips and played music. I played in award-winning Dixieland and swing bands here on this stage. I played in orchestras and wind bands. And in the days when the two schools were kept quite separate, these were some of the few opportunities that the boys from Quakes and the girls from here at the high school had to come together to be sociable. It's quite interesting now when I discuss all of these opportunities that I had at Quakes with my wife, who's a consultant dermatologist. She went to a state school in Newcastle, and she's very envious of the opportunities that I had and the opportunities that you are now having. She was adamant that she wanted for our children to be given those opportunities as well, and it's with some regret that I sent them to GSAL. But your parents have given you these opportunities, and I would urge you to grasp them. Take everything that comes in your direction with both hands, because it will develop your personality for years to come. Because I had regular periods of my childhood, school grades weren't exactly what probably they should have been. The marks that I got in mock exams were nothing to be particularly proud of, but when it came to the real thing, fortunately, I managed to pull it out of the bag. Well, I did on most occasions anyway. Let's just say that French was never my strongest subject. We were always advised that we should try and keep our educational path as broad as possible. Having studied chemistry, biology and maths, it was recommended that I did French AS. My dad was a physics teacher in Morley, so there was never any chance of me doing that at A-level. On the morning that the French AS results were published, and I saw my D grade alongside my name, I remember driving home to REM, Everybody Hurts Sometime. And trust me, that was perfect music for the reaction I got from my parents when I got home. But because of the inconsistencies in my exam results, it was never straightforward as to which university I was going to apply for. I thought it would be a good day out to visit Cambridge when they had their open day. And on my return, I stated that I might as well give it a go, because at that stage, you could only apply to 5 universities to do medicine, and Cambridge offered a medical sciences degree that didn't count as one of those choices. St Catherine's College was a good choice for me, because Quakes had had boys go there in the 2 previous years, one to study law and one to study medicine. There's no doubt that colleges do have affinities for certain schools, so please do bear that in mind if you are applying to universities and colleges. They were a successful hockey college, and at that time the only college to have their own AstroTurf. It's an average sized college. They took about 10 medics at the time. They didn't have the finances of a St John's or a Trinity College, and so there was no opportunity for grants to allow me to go on holidays during the time off or to buy books, etc. But because they were a small college, they also didn't ask for step or special grades, which was an important consideration for me. I went for an interview and, to be quite honest, quite enjoyed the occasion. If I could give you one piece of advice whenever you go to either a university or a job interview, it's think out loud. I remember being asked what we were doing in maths at the time. To this day, I use vectors on a daily basis to find microscopic blood vessels on a patient's abdomen that I dissect out in the reconstruction of breasts following a mastectomy. I really think that your ability to demonstrate logical thinking and answer a question by working it out in front of an interviewer is so much more impressive than simply having an answer which you've pre-learned and have regurgitated. To this day, I interview medical students, junior doctors, higher surgical trainees, and fellow consultants for jobs. Because interview processes have to be so transparent, everybody knows pretty much the questions that they're going to be asked. You can go on courses, you can read in books how to answer these questions. But when we hear the same answer 20 times a day, it becomes tedious and boring listening to those answers. If we hear something novel, then it's much more interesting and really piques our interest in that individual candidate. So I was fortunate enough to be offered a place at St Catherine's, depending on me achieving 3 grade A's at A-level. Unfortunately, with my general studies, I got 4. I still have nightmares about going into my chemistry A-level exam, having not revised, and I honestly really do. I look around at everyone else in the Queggs gym. They're all 18-year-olds, and I'm a 40-something-year-old with a family, with a house, with a mortgage, and everything relies upon me passing an exam that I've done absolutely no preparation for. Your A-levels are vitally important to your future. But university really is the best time of your life. The freedom that it brings and the amazing opportunities. A whole new group of like-minded people from all areas of the world studying different subjects all thrown together. Yes, Cambridge is an odd place. In the middle of Parker's Piece, which is this little park, on one side you have the university side of Cambridge, and on the other side you have the town side. And there's a lamppost right in the middle of that area on which someone has written reality checkpoint. On one side you've got the town, and then you've got what really isn't reality on the university side. Having spent 3 years on the university side, and then another 2.5 years on the town side whilst at Adam Brooks Hospital, reality checkpoint is the perfect description. I was taught and I sat exams in buildings that tourists would go past and take photographs of. I was lectured and supervised by the man who discovered the BRCA gene, the gene which is almost entirely responsible for the development of breast cancer. I was lectured by the man who was going to be the UK's first astronaut until he got a cold the week before he was due to go into space. I lived with an Irish medic and 2 economists. The medic that I lived with, he would revise all night before an exam. He would take a kettle and a toaster into the library with him, and then he'd sleep a few hours before going to his exam the next day. The economists would love how little work they had to do in comparison to us. Mr. Eggleston will know that only too well. One of the lads I played with played football for the university, and the other guy played rugby for Wales and for the university. Every year we went to the varsity match down at Twickenham as his guest, and we went to the after-match celebrations, or aftermath, as my spell check prefers. Cambridge is targeted by all the investment bankers. At the time, that was Goldman Sachs, JP Morgan, and Price Waterhouse. They would come around in the first term and put on events to which you could go, encouraging students to apply for placements with them. But despite having no intention of giving up medicine, these were always a great opportunity for us to put on a tie and a blazer and make the most of their hospitality. Occasionally, we'd have to talk to a representative for one of the institutions. And despite our honesty that we were really only there for the free food and drink, they put on a convincing argument that as medics, we were systematic thinkers, gregarious people, just what the world of investment banking was looking for. And it sometimes makes me wonder quite how different my world could have been if I'd have gone down that line. But Cambridge is bizarre in so many different ways. You're only there for 8-week terms, and actually 6 weeks in the final term, which means that you're actually away from the university more than you're there. This gives lecturers time to do their research and gives students time away to earn money. But everybody who suffers and studies at Cambridge does an intercalated year, and this means that you get a Bachelor of Arts degree along with everyone else at the university after 3 years. If you manage to stay out of prison for the next 2 years, your Bachelor of Arts automatically becomes a Master of Arts degree. Don't let anyone tell you differently. The exams are difficult. You may have 2 exams a day for 6 days a week over a 2-week period. But after that, the summer balls give you a real opportunity to make up for lost time. There are garden parties most days and all-night balls, which are usually finished off by a dip in the can the next morning. And these are amazing memories. In the holidays, I came home and worked at the Dam Inn in New Miller Dam. I worked as a porter at Stanley Royd Hospital, which is the old psychiatric hospital next to Pinderfields, which are now residential flats. I worked in the kitchens and as a nursing auxiliary at Pinderfields Hospital, and these were amazing experiences, showing me what the true heartbeat of a hospital is. It's really important that you realise, whatever industry you go into, that there are less glamorous sides of the institutions in which you work, and having first-hand experience of them will serve you well. The understanding and the empathy that you will receive from others will serve you. There's a strong possibility that while you're at university, you may meet your partner for life, as I did. After graduating in your preclinical studies at Cambridge, at the time, many students went off to Oxford or a London medical school, but I believe now most students stay at Addenbrooke's Hospital. The clinical part, I was president of the Medical School Sports Society and had to run the induction for the new trainees entering the medical school. It's at that point that I met my wife-to-be, and the rest is history. So having graduated in December 1999, I worked as a medical junior doctor in Bury St Edmunds and in surgery at Addenbrooke's Hospital. It was at that point that I decided I wanted to return to Yorkshire rather than stay in East Anglia, and I returned to do the basic surgical training scheme here in Yorkshire. Originally, I wanted to be a paediatric surgeon, but my experiences of doing this dissuaded me from pursuing it further. So it was at that point that I looked at what it was that attracted me to paediatric surgery: the desire to restore normal form and function, to work with delicate tissues, taking time and working with precision, to recreate normality with the skills that were transferable from paediatric to plastic surgery. Throughout my junior doctor career, there were changes in the way that we worked followed me through. I was in the group that used to work 100 to 120 hours a week. We would do a full day on call or a weekend on call, starting on Friday morning and finishing on Monday evening. This then changed to what we see now, with individuals doing shift patterns, working weeks of nights, and then having about 36 hours to completely turn around your body clock and get back onto a day shift pattern. It's always been the case that competition for places in plastic surgery is high. By the time I'd decided upon plastic surgery, I'd completed 2.5 years of surgical training and a year as a house officer, what you can see up there in blue and green. I'd passed the MRCS exam, membership of the Royal College of Surgeons, and had completed numerous courses. I was fortunate enough, through competitive interview, to get a job at Pinderfields in plastic surgery as an SHO. I worked there for a year. I did a further year in Hull, and then I worked in Leeds for 9 months before being offered a non-training registrar role. This is known as an LAT, a local associate for training. I did this for a further year before receiving a training post in the last round before the whole system changed yet again. Now, progress through the ranks of junior doctor to training has become a lot more streamlined. And although this is good in some respects, it has certain disadvantages for those individuals who don't know what area they want to specialise in. The apprentice nature of being a junior doctor means that you learn a lot from experience. With European restrictions on how long we can work, trainees have less opportunities to see the conditions and procedures that they're going to have to carry out as consultants, and they enter that role with less knowledge and experience. So during my SPR training, I spent a year in Bradford, 1 in Hull, 2 years in Wakefield and 2 years in Leeds. I experienced all the subspecialty areas of plastic surgery: head and neck, trauma, hand surgery, skin cancer, sarcomas, which are soft tissue tumours, and breast surgery with reconstruction. And it was this latter area that really grabbed my interest. Patients are otherwise fit and well, and through no fault of their own, they've had their identity stripped away. Their femininity has literally threatened their lives. I often hear stories of women who have had mastectomies who cannot undress with the light on. They will not undress in front of a mirror, or they will not undress in front of their partners. They buy ill-fitting clothes to cover up their asymmetry. Being allowed to work with these patients is a real honour. To share in this period of their lives and be allowed to work with them is a real privilege. I closely work with a charity called Bosom Friends in Bradford. They work to inform patients and support them throughout their treatment. Knowledge and information for these patients is incredibly powerful and allows them to be part of their treatment decisions, giving them control at a time of their lives when everything seems to be falling apart. Must admit, the surgery is stressful. I find it physically and mentally exhausting. There's a saying that the only way not to get complications as a surgeon is not to operate. But sometimes things don't go to plan. Sometimes, due to the vagaries of the human body, due to anatomical variations which are beyond my control, things just simply will not work. And I take this pretty badly. I feel a great responsibility towards the patients I operate on. And although I've only had 3 major procedures which haven't worked, I know these women incredibly well. Patients who sail through their surgery just carry on. And although we do get to know each other, I don't know them nearly as well. But I take time to put things right with the patients who haven't got the outcome that they expect. We reconstruct the breast by an alternative method, but I'm acutely aware that this is not what the patient was expecting when they set out on their journey. I have many more patients who are delighted with the outcome of their surgery. They tell me that their lives have returned to the way that they were before a cancer diagnosis. And this is a wonderfully rewarding part of my job. The letters and cards that I receive make it all seem worthwhile, despite the long hours and the stressful procedure. And this is just one such letter, and I think it's worth reading just so you can appreciate what these ladies do actually go through. Sorry, it's not all quite fitting on there. So no doubt the impression that many of you have of plastic surgeries, of rhinoplasties, nose jobs, tummy tucks, facelifts and boob jobs. And whilst private practice does play a role in my weekly activities, this is probably only a day and a half or so a week. Many plastic surgeons will commit significantly more time to fulfill this gap in the market. But the challenges that these patients present are significant. I'd rather spend my time training junior doctors and committing more time to my NHS patients, spending time with my family. But this isn't to criticise those doctors who do perform this work outside of the NHS. There's clearly a demand for such work, and the benefits that patients receive are significant. With funding restrictions in the NHS, the need to provide such a service becomes significantly greater, and we see less and less things now being covered by the NHS. I want to just run through a few things that we do in our practice on a day-to-day basis. I think you've all been warned that there might be some pictures in here that you might, this one less so. So these are quite common things. Patients who present with swellings, just simple fatty lumps, lipomas on the back, benign conditions that just require excision. Anyone know what this is? Skin cancer, any particular type of skin cancer? I'm sure you all know. So, yeah, it's melanoma. So the mnemonic for melanoma, A, B, C, D, E. So if the lesion is asymmetrical, if it's got an irregular border, if it's got various colours within it, if the diameter is greater than about 7 millimetres, we tend to be pretty poor at judging sizes, so if you can cover it with the end of a pencil rubber, it's usually less than 7 millimetres. If it's an evolving lesion, if you've been in an environment whereby you might be predisposed to this, so repeated episodes of blistering, sunburn are what give you melanomas. So this is an absolute classical melanoma. It's asymmetrical, it's got an irregular outline to it, it's got multiple different colours within it. You can't tell the diameter from that, but it's, let's for argument's sake, 8 to 10 millimetres, and it's in a patient who's had lots of sunburn. In contrast to this, which is a benign lesion, which I did a skin cancer clinic this morning, and GPs probably sent half a dozen of these in thinking that they were melanomas. It's got a nice defined well border. It's pretty much one colour throughout. It's reasonably symmetrical. So for argument's sake, it's small and it's in a patient who hasn't got a predisposition. This is another type of skin cancer. This is what's known as a squamous cell carcinoma, which is less severe than melanoma, but worse than other types. It needs aggressive treatment through surgery. What we do for this patient is to mark it out with a 5mm margin all the way around it. And this is where plastic surgery comes into its own. Because this patient has lots of laxity in the area, we can move the tissue up from just behind it, rotate that round into the defect that we made, and borrow pieces of paper to put her back together again in both an aesthetic and cosmetic manner. This is the final type, the basal cell carcinoma. Most 70 or 80-year-olds will get one of these, or if they don't know they have one, they will do. This is quite an unlucky place to get one on the lower eyelid. They tend to be caused by chronic sun exposure over a long period of time. We've taken away this lady's lower eyelid and then gone up into the temple area and shifted all that skin across to reconstruct a lower eyelid. Hopefully she's going to end up with a good cosmetic result. As well, most importantly, is a good oncological result that we've cured her of her BCC, which is the primary concern. But this is what I spend most of my time doing. This lady's had a left-sided mastectomy. She's of a typical age and a typical Bradford body habitus, and she's got quite a significant scar that I'm sure you could imagine is difficult for her to live with in terms of asymmetry. The red square is because there was something unpleasant behind the red square. I was talking to Mr. Eggleston beforehand, and we mentioned the fact that those of you in the upper six, if you do go to university this year, you may be holding a knife and dissecting a cadaver. So hopefully nothing that I'm going to show you today is going to be too unpleasant, because you're going to be doing it yourselves in the not too distant future. But this is an operating theatre. You know, this is one of my colleagues who now just does private practice. This is the setup. We've got a microscope in there, we've got a scrub nurse, you know, we have glasses on that allow us to see things at about 2.5 times magnification. And behind that red square is a patient. He's holding a bit of tissue that used to belong to that patient's abdomen and is now going to create their breast. These are the microscopic tools of my trade. Jeweler's forceps, things that really were used for watchmaking in the distant past. We use tiny sutures that are smaller than a hair, in order to put people back together again. These are the blood vessels that we put back together. So we do effectively a tummy tuck. We keep that piece of tissue attached to a blood vessel in the groin. We open up the chest, we take out a rib, we find the blood vessels underneath the rib. And the vessel that you can see on the right-hand side is the internal mammary artery underneath the rib. The vessel you can see on the left-hand side used to be in the groin and has been completely disconnected from the body. We're going to put those arteries back together again so that blood flows through this piece of abdominal tissue that we've disconnected. And these are images down the microscope. This is the venous side, so we have to put the artery on so blood flows into the flap. We have to put a vein together so blood flows out of the flap. As you can see, the vessel on the right-hand side is almost unicellular. It's incredibly thin, and if patients have had radiotherapy for their breast disease, that is very friable and easily tooled. So we stitch these vessels together. It usually takes about 8 to 10 sutures to put them back together again. And actually doing that takes probably about half an hour per vessel. We tie all those off. As you can see, it's very delicate work. We don't have a coffee on the morning of doing that because you want to reduce the tremor that you have. And then eventually there you can see the vessels back together with blood flowing from left to right through the artery into the flap and from right to left through the vein back into the patient. And there's the patient after the surgery, significantly after the surgery, maybe 6 months down the line. So you can see that she has got a symmetrical reconstruction. She's got the scars of a mastectomy still, but she has a piece of her own tissue used to reconstruct her breast. She's had a tummy tuck to harvest that piece of tissue, and her belly button is her own belly button, that has been brought out through a piece of tissue that used to be in the top part of her abdomen. There you can see her abdominal closure. Yes, she's got a scar that was hip to hip, but most ladies of that age, of that body habitus, are quite pleased to have a tummy tuck thrown in with their breast reconstruction. This other lady a bit further on down the line, she's got the same or very similar scars. She's also now undergone a nipple reconstruction and a tattoo to her areolas in order to give her an aesthetic as well as a good functional reconstruction. This patient's slightly different. So those first two ladies have had a mastectomy, have had maybe radiotherapy, they've gone away, they've contemplated where they want to be, and they've come back subsequently to have what we call a delayed reconstruction. Their reconstruction has been subsequent to their mastectomy. This lady's had her reconstruction performed at the same time as her mastectomy. The difference there being that we can maintain the skin envelope of her breast. So the mastectomy has been performed through the areolus. The breast tissue has been taken out as an oncological procedure, and then we've used the abdominal tissue to fill the cavity of her skin envelope and just maintain a small area of the abdominal skin that we use to monitor the success of the operation. And that will form her areolus, through which will have a tattoo. The aesthetic results are far better in this operation, but ironically, patient satisfaction is probably slightly worse. The reason being that the ladies who've had the delayed reconstruction have had to live with their mastectomy scar, they've had to live with the discomfort, they've had to live with the asymmetry, and therefore they're significantly more grateful for the outcome they get than these ladies who've gone to sleep with a breast and woken up with a reconstruction. And here you can see the lady who's had a nipple reconstruction but not yet had the areola tattoo. So using local tissues, moving those tissues around, we can create projection. Then we can also use tattoos to create highlights on the nipple or shadows, which give the illusion of projection. And ladies end up with, not necessarily perfectly symmetrical results, but results that they can live with, results that are far better than a mastectomy scar. And also a very natural feeling breast, in contrast to an implant-based reconstruction, which is really the alternative, a much shorter operation, and an operation which in the long term will require multiple revisions and repeat operations, whereas this, after a year, I can probably discharge that patient and never have to see them again. But it's not always possible to do that type of operation. This patient, you'll see on the right side of her abdomen, has a scar which prevents her from being able to have the abdominal procedure. So we've used tissue from her back, we've used an implant in order to put her back together again. There you can see, There you can see the scar on her back, which is the result of us taking tissue from that area in order to reconstruct a breast, which we've managed to hide within her bra strap. And then finally, this lady is what's known as a quaternary reconstruction. She has had an implant-based reconstruction on the left-hand side. It's not been successful. She's had problems with her implant. She's had multiple surgeries on her abdomen for various other reasons. And we've had to take all that to pieces and put her back together again. And yes, it's not a symmetrical reconstruction, but it's far better than that she started with. It's not all reconstruction. Some patients are born with asymmetrical breasts, and we've done reductions and uplifts on both sides to give this lady a more symmetrical breast. And then finally, this is a lady who, when I explained to her that she was going to have an areola tattoo in order to improve the cosmesis of her reconstruction, she decided that she'd take it upon herself to do her own tattoo. The bottom bit has been left to put my name on. She wanted to put by Mr. Andrew Williams, but I declined greatly. It's not all breast reconstruction. I do an awful lot of trauma. This is a typical injury that we see almost on a daily basis. A child trapped their finger in a door that we need to put back together again. This is somebody who's cut their finger with a knife and has probably damaged blood vessels, tendons, nerves. People who get foreign bodies in their hands, piece of wood. People who get shot. There's the foreign body we've removed from that patient. This is what's known as a paronychia, hand infection, very common in nail biters. Please don't bite your nails. People lose fingers because they bite their nails. So nasty infections can cause significant problems. This is what's known as a septic arthritis. The patient's got an infection within their joint, or a flexor sheath infection. They have got an infection on the palm side of their finger, which again is a finger-threatening injury. Significant infections can get into the bone, cause what's known as osteomyelitis. And although things can look very similar, this is a patient who's got gout. Certainly isn't anything which is infectious and needs treating by rheumatologists. We see a lot of fractures of fingers. This patient was walking their dog, and the dog pulled on the lead, which got wrapped around their finger and broke their finger. We use wires to put these fractures back together again. For about 6 weeks, those wires will come out. Patients try to wire their own fingers. This guy was walking around home base, didn't know what a nail gun did, so picked it up and tried it. And you can see the nail in his hand. This patient was climbing over a fence, got their finger caught on the fence. And there's the rest of his finger that we're going to put back on again. There it is, all back on. Just look through those pictures. I was talking to Mr. Eggleston just before Christmas. I got called in to see a patient who had been attacked by his 4 brother-in-laws, each wielding a machete. One hand off on one, and then 4 fingers off on the other hand. 10 hours later, we put everything back on again. These are exciting things to get referred. This is a very common injury we see. This is a 5th metacarpal fracture, this bone in your hand. These patients, it's known as a boxer's fracture. It's very common. You can see another exactly the same, pretty much. There's a saying, a fracture is a soft tissue injury with an associated broken bone. So these patients, when they hit people, hit them in the mouth. Your mouth is full of bacteria, and they get nasty infections within their hands as well as the fracture. So these need washing out. Patients don't just present with 1 fracture, they often have 2. This guy's got a 5th and a 4th metacarpal fracture, so his ring bone his hand is also fractured. He's got injuries of the soft tissues to both that we've had to wash out and clean to stop them getting infected. So there's the fracture. We're going to put a plate on that to fix it. Fortunately, this guy is a recurrent offender. He came back a few weeks later, having got into another fight, broken the bone next to it. So taken to theatre, we put a plate on that. He comes back having bent the plate, having had another fight and got a fracture, which you can just see towards the finger end, just beyond it, and you do sometimes wonder why we bother. There he is down the line. You can see his bones are nice and thickened up where he's had the fractures previously. But it's not all about, you guys are too young to remember this programme. This was a series on what was equivalent to Netflix at the time, about some aesthetic surgeons. There is also a degree of aesthetic surgery involved in what I do, and that, some of the things that we do in aesthetic surgery, the skills that we learn there are transferable to what we do otherwise. But the world of medicine, as I've said, is very different. Waiting lists are now up to 2 years rather than 18 weeks. This sort of PPE is what we do on a daily basis when we go onto the COVID wards to see patients that we've got who have other plastic surgery type problems. And it's a difficult industry in which we work at the moment. It's still enjoyable, but it is very different. So I suppose the big question is, would I do it all again? And I suppose it's a tricky question. I think the answer is yes, because there's nothing else that I'd rather do. I think if I was to talk to my younger self, I'd probably suggest I take on less responsibility and allow myself more free time. I do become incredibly frustrated when I see colleagues and other people who neglect their responsibilities and that don't perform the tasks expected of them to the level that I would expect. It's no longer sufficient to work in a region and be liked. Junior doctors, upon leaving medical school, are often placed into jobs that they don't want to be in. They have to apply to progress through a series of national selection. And this can mean that on a Tuesday, you're doing a job in Aberdeen, and on the Wednesday, you have to start a new job in Portsmouth. I'm not quite sure how 25 to 20-year-old doctors are supposed to have what is known as a work-life balance in these circumstances. They're at a stage in their lives when they want to settle down with a partner, buy a house, and start a family. And at the time when they do have busy and stressful jobs and work on sociable hours, they have to prepare for exams, and they're continually assessed as to the progress that they're making. They're continually scrutinised in the media and are used as a political football. There's no doubt that doctors are well paid and significantly above the national average. However, when you compare what they're doing to the work that their peers are doing, peers that have done similarly well at school and university, I think there's very little to encourage high achievers into a world of medicine. As I said at the beginning, I'm training program director for core surgical training, junior doctors that are both 3 and 4 years out of medical school. And at this level, there are significant issues faced by junior doctors, and they're becoming increasingly apparent. There are about 140 core surgical trainees throughout the Yorkshire region, and it's quite remarkable that given the fact these are all high academic achievers, they do still struggle to progress through a well-mapped out programme. It's a time when they have to decide which surgical speciality they want to pursue. There's another round of national selection, upon which the success was partly dependent upon the popularity of the speciality that the trainees want to go into. Those who don't progress can continue to gain experience in their chosen speciality until the national selection procedure is repeated the following year. Ironically, repeated attempts are viewed negatively and are seen as failure to progress. I've also recently taken up the role of Deputy Programme Director for Plastic Surgery, and I look after doctors there who have finally decided they want to do plastic surgery and go into a further 6-year training programme. Final hurdle that I and they will overcome to become a consultant plastic surgeon is the fellowship exam, which is the FRCS PLAST. This is a 2-day exam, and most registrars will begin revising about 6 months before taking the first part. You sit 2 3-hour multiple choice papers in the DVLA test centre. The contrast couldn't be starker. I don't know if any of you have sat a driving test exam in the test centre, but you get people coming in every half an hour, people from very different backgrounds, and having to sit there for 3 hours doing your FRCS PLAST exam, being asked quite involved and deep questions is pretty tricky. But if you're lucky enough to get through this first part, you sit a 2-day clinical exam where you have to go somewhere else in the country. And this is an opportunity for senior consultants to assess whether or not they feel you would make a good colleague. You do both short and long cases on the first day, and on the second day you sit 4 vivas, and it is undoubtedly the worst experience of my life. You would feel like you're just being interrogated for 2 days consistently. And for this privilege, you charge £2,000. As well as junior doctor working patterns, there's been pay debates recently. You may have heard that the NHS staff have been offered a 3% pay rise. That's in contrast to dustbin men who've been given an 11% pay rise. So it was very nice to be clapped on a Thursday evening, but 3% doesn't pay the bills for all those nurses, unfortunately. Junior doctors have had to go on strike in order to get the work that they're doing recognised and the shift patterns that they're having to work. And we pay thousands of pounds in insurance every year. We pay GMC membership, the General Medical Council, and all they do is strike you off if you do anything wrong. I'm a member of the British Association of Plastic Surgeons, the British Association of Aesthetic Plastic Surgeons, the British Medical Association, the Royal College of Surgeons of Edinburgh and of London, and all that totals about £10,000 with my indemnity. There's no doubt that I feel very privileged to do the job that I do, but I do occasionally need to be reminded of this. My family is my greatest priority, and as I say, it was very difficult for me to send my kids to GSAL, having been at Quakes myself. Despite the fact that they're there, they seem to be doing okay. But it's really important that you guys keep your interests outside of medicine as well, if that's where you end up, or in whatever profession you end up doing. So I coach the Eastern Central Regional Cricket Team. I coach my local under-15s cricket team. I look after the West Park Leeds rugby team. And I support my children in their football, cricket, rugby, hockey and netball fixtures, both at school and outside of school. And it's these activities that keep me grounded and realise that there is a life outside of medicine. And I put these slides in at the last minute. These are something which I was forwarded by the Royal College of Surgeons eventually after asking for it. This would be a really useful place that I'd signpost you to if you were interested in a career of surgery, career in surgery. So, Women in Surgery is a network of ladies who have been sat where you are and have got to the highest pinnacle within their surgical career. And they're there to inspire you guys to follow in their footsteps. You'll all know that you apply for a medical position through the UCAS scheme, that you will expect to spend between 4 and 6 years studying medicine at university if you're successful at getting high grades at A level. On completing that degree, you will get a Bachelor of Medicine, Bachelor of Surgery, and then you'll go on to the provisional registration programme with the General Medical Council. Spend 2 years as a foundation year training, and then we'll move on to core surgical training, at which point you will be expected to decide which subspecialty area you want to go into. You'll then enter specialty training, and after doing that for 6 years, you will become a consultant. There are lots of extra years that you can take within that scheme, doing fellowships, gaining extra experience, but that would be the most streamlined version. There are many different areas within surgery that you may decide to specialise, and it's really important that you get experience of each of those areas. As I said, I would have been a paediatric surgeon had I not experienced it and decided that that wasn't the way that I saw my life progressing. But it's not all about operating. I very much thought when I was sat at your stage that the great thing about being a doctor would be that you couldn't take your work home with you. Well, how wrong I was. Yes, there is the time that you spend in theatres, there's time that you spend on ward rounds, seeing patients before surgery, after surgery, patients who are admitted that don't even need surgery. You spend time in outpatient clinics, diagnosing problems, planning treatment, and then seeing patients to see how they recover after their treatment and making sure they don't get recurrences. There's an awful lot of administration, there's a lot of paperwork. If it isn't written down, it never happened. It's really important that you keep accurate records, because lawyers will come after you 6, 8 years later, and if it's not written down, you haven't got a hope in hell of remembering what you did for that patient. There's also a lot of supporting work that we do, training, teaching on courses, and I'm heavily involved with the Royal College of Surgeons and medical schools, helping out teaching at Leeds University. And then you can do research. Within plastic surgery, it will be expected that you have written multiple papers in peer-reviewed journals, that you've been to conferences to present novel work. And plastic surgery is quite a young speciality. It was really born out of the Second World War, when people started doing novel techniques in order to reconstruct individuals who've been injured in the wars. So, a few take-home messages for you. Make the most of the opportunities that are given to you. Hopefully being sat here, you're demonstrating that now. A lot of people have made a lot of sacrifices for you to be in this position, to send you to this school. And you owe it to them, and you owe it to yourselves to make the most of those opportunities. Always try, and always try your hardest. You'll never regret putting in extra time and effort, but you will regret not giving it everything. Whether it's in sport or friendships, always give it your best shot. You never know, it might just pay off one day. And think about those people around you. You never know what the person sat next to you, in front of you, behind you is going to become. One day you might need their help and guidance. Thank you very much.
Many thanks for that. And we do have about 5 or 6 minutes. Anybody got any questions that they would like to ask?
How you said it, obviously it's a lot of work, uni and then the training.
Yeah.
Is there still time for social stuff?
Oh, God, yeah. Yeah, no, I had a lot of fun at university. The friends that I developed while I was at university. They're friends for life. You know, I've been over to Australia, I've been over to America to see those guys. I'm godparents to their kids. You know, sport, activities, things like that are a massive part of university life. And in medicine, you know, your days are more planned out. They're busier than most other people at university. You know, you've got lectures, you've got dissections, you've got practicals, etc. And some courses you might only have 2 or 3 days of structured activities. At Cambridge, because it's 8-week terms, like I said, you will do probably 5.5 days a week of structured activities, and then you get a Wednesday afternoon off to do sport. And then in the evening, you will have supervisions, which are small group teachings. Yeah, it's busy, but I have plenty of spare time.
Anyone else? Paul?
And what were your reasons for like moving away from paediatric surgery?
Okay, so I did paediatric surgery in Leeds. No one's parents are paediatric surgeons in Leeds, are they? Good. And I worked with a chap. Well, it's okay. I was an SHO. I was a junior doctor. I was on a night shift, and there's a baby that was going to have an operation because the last part of their bowel wasn't working properly, and they were going to have an operation whereby that part of the bowel was resected and the rest of it was pulled through to make it function. And I'd worked up this child who was on the neonatal intensive care unit for their surgery the next day, and they were fine. I'd gone to bed at 3 o'clock in the morning, got up at 5 o'clock to make sure everything was still all right. And during that time, the consultant who was doing the surgery the next day had come in to see the baby, got a consultant radiologist out of bed to do an investigation, which had already been performed. But he wasn't happy that he thought everything was as it was going to be. And it was. Everything was there, everything was intact, everything was just as it wanted to be. And that was the trigger that made me think, when I'm 65, I don't want to be doing that. I don't want to be the person who is the last stage to a 24-week-old premature baby between life and death. You know, when everyone else has tried to get intravenous access into a baby, no one else has succeeded. At 4 o'clock in the morning, they're going to call me. I'm going to be an old man by that stage, and I'm going to have to take this baby to theatre, and I'm going to have to do an operation that is the difference between life and death. And whilst, you know, that is a big responsibility, and whatever you do, there are big responsibilities, there were things that I could get out of plastic surgery that were, you know, equivalent. And, you know, the other side of it is that you do, whatever you do is going to be a vocation. You're going to work hard. And, you know, realistically, I'm being absolutely honest with you, there's no private practice in paediatric surgery. Children get the operations that they want. They're prioritised within the NHS. And if you're going to work that hard, why shouldn't you earn a little bit of money on the side? Why shouldn't you have a quality of life so you can send your kids to private school, so you can drive a nice car, live in a nice house, go on nice holidays? You know, that's the bottom line. Yes, we do the jobs we do because we love them, because we want to educate, because we want to train, because we want to make people well. We want to give ladies their lives back. But we also do it because we want to earn some money and have a good quality of life. And, you know, that's the realism of life.
What's the life plan after this? Like,
Me, retirement. No, go on, sorry.
like when you stop operating, like would we want to?
Yeah. So, you know, the breast reconstructions that I showed you, I start at 8 o'clock in the morning, I finish at 6 o'clock at night. The plan there is to go home and relax. But, you know, I will operate until I retire. That's the reality of it. But by diversifying, by going into education and training, it gives you something else to do outside of, you know, the day-to-day operating as well. And you do different things. I won't be doing that type of surgery until I retire, I hope, because younger surgeons will come up that have been through training, have been through fellowships, and, you know, they'll be aware of the new techniques. And it's not appropriate at that stage that I do it, but I will be doing other things.
You said that you prioritise family.
Yep.
Like a lot. Would you say you still got to, as you were obviously like busy working, would you say you still got to like see your kids grow up and be like very present in that?
Definitely. So there was a guy who I worked with in Leeds who said that he worked every Saturday in the private sector, never saw his kids play football, rugby, hockey, whatever they did. And I vowed to never do that. So yes, I do work weekends. I worked last weekend in the NHS. But I don't commit to private practice at their detriment. So I was telling David that tonight I leave here, I go pick up one child, take them home to do some homework, go and pick up the other one, then take one of them to hockey, then go on to Headingley, take one of them to cricket, come back, pick one up from hockey, go pick the other one up from cricket, go home, and I get home about 9:30. And that's fine, because that's what you do as a father, that's what you do as a parent. And sometimes work gets in the way. My wife, as I say, is a doctor as well. She's busy, but together you're a team, and your family is the priority, and you work around it. Before you have kids, you always try and make sure your on-calls are at the same time, so that you get to spend more time together. And now we make sure that our on-calls are on different days, so that someone's always at home to be with them and to take them to their various activities.
Would you say that the placements you did through medical school and training really helped shape where you wanted to end up?
Yeah, definitely. So I knew from I thought I knew from a very early stage I wanted to do paediatric surgery. So the posts I applied for in Addenbrooke's were paediatric surgery and colorectal surgery, because they came together as a job, and I thoroughly enjoyed it. And then I wanted to come back to Yorkshire, and you apply for a training scheme. And I did A&E, orthopaedic surgery, general surgery, paediatric surgery, and cardiothoracic surgery during that time. And I still use a lot of the skills that I learnt in those jobs, but they gave me a good exposure to surgery in general. And then everything I did gave me something, definitely. But being able to speak to an orthopaedic surgeon, because I've had experience in that and understand what they do, is vitally important. But also what's vitally important is being able to speak to the porters, because I was a porter, being able to speak to the nursing auxiliaries, the kitchen staff, those sort of people. And it breaks my heart to see other doctors walking down a corridor not saying hello to each other, and not having any sort of social skills. Talking down to other people who work in hospitals. Hospitals wouldn't work without doctors, but they also wouldn't work without nurses, without porters, without kitchen staff, without cleaners. All these people are vitally important to the way that a hospital works. And the experience that you could gain in any industry by working at lower levels and getting experience of the whole industry is really important. You need to understand the cogs to understand how the machine works.
One more question, if anybody's got any.
How many things did you really regret doing?
French AS. No, I don't think I do. You can find very specific instances that I regret, taking that blood vessel rather than that blood vessel. But I don't, in the general scheme of things, I don't think there's an awful lot of regrets that I have. I'm delighted that I gave myself a chance to go to Cambridge. I'm delighted that I, took that opportunity, and pleased that I came back. A lot of people talk about going to London and experiencing working in London. I honestly don't regret that. I enjoy going to London and experiencing it, and I enjoy even more leaving and coming back to Yorkshire. I'm pleased that I'm doing plastic surgery. I'm pleased that I'm doing breast reconstruction rather than the other specialities. In those other specialities, people have, through bad life choices, have got themselves head and neck cancer, have got themselves different types of cancer, have got themselves different types of trauma. But, these ladies who've got breast cancer, they, through no fault of their own, have suffered a life-threatening illness. And all the ladies that you saw there, they're all part of Bosom Friends. They all would want me to say, you know, that 1 in 7 of you sat here today will get breast cancer. And it's vitally important that you know, are aware of that and that you examine your breasts on a regular basis, and that if you spot anything, you go and see your GP immediately. And it's, you know, I'm sorry, it's a harsh thing to say, but you know, it is a terrible, terrible disease. And for me, getting the opportunity to work with those ladies in a really sensitive, difficult time of their lives, it is, you know, a real privilege to be part of their families during that time, and to watch what they go through, be part of their cancer treatment, and see their recovery is quite remarkable. So, you know, I don't think there is anything I regret. I would do it all again.
Andrew, thank you very much.
Could talk to
Go
me.
on, go on.
What stage of cancer would it be at?
Various stages. So, I mean, because it's a big undertaking, they tend to be people who have quite a good prognosis, because if they have a bad prognosis, you really don't want to be undergoing a 12-hour operation, and an operation that, you know, is going to have a significant recovery. It's better that they live their lives if they've got a poor prognosis, if they're a later stage disease.
Andrew, thank you so much. I hope you found that informative. I hope you found it inspirational. You will not outgrow embarrassing now. You will not meet a nice man. I know Emily Williams since a really teenager. I knew what he wanted to do. I know the work that's gone on behind the scenes with the support of his family. More recently with his wife, he's gone to great lengths. Someone said to me recently, I'm not going to embarrass you in saying that they said who said this. Quite remarkable man. I think the important thing from me to you is, I'm not going to say a few years ago, it's a little bit longer than that. He was here, he was one of you. And I sincerely hope that in years to come, one of you or some of you are stood here delivering a simple lecture like this. And obviously you go on for great heights that he's done. I'm a bit squeamish, girls, if I'm perfectly honest. It took me today because what he does is fascinating and it is life-saving. And hopefully that you will follow his footsteps. But finally, we'd just like to say, Mr. Andrew Williams, thank you.